So again, right, just review those pictures that I just shown you, which is this one right here. Know what causes aphasis. You will see something like that. Know this one as well, and this one. Now, obviously, you'll probably see this one because it regards the heart, and then this one because it regards the SA node. And those are very important functions, very important slides to understand. So I wouldn't ask like, what causes a depolarization phase in the SA node, right? Because I expect you guys to know that. I would ask questions like, all right, so if you have too much potassium, right, and it's this picture, would you have a problem with figure, number 1, number 2, or number 3? So then you have to figure out, all right, well, I have a lot of, or, I have too much potassium. So what's potassium efflux right here? Well, what does it do? It allows us to repolarize. If I have too much potassium extracellularly, then my repolarization goes very, very low, making it harder to stimulate later on, right? So just keep that in mind. I will have questions like that regarding either this graph or the previous one that I just mentioned, which is that one about cardiac muscle, right? So in this example, I might have a question regarding, all right, where would you see the greatest issue if I have not enough calcium in my diet? Well, calcium is only going to be coming in during this second plateau phase right here. So you should see issues in this second plateau phase. So that's the kind of questions I would ask. And there could be a couple of questions like that. So just a little warning, since you're here, only one again for the week. So just keep in mind, I would ask those questions. Now let's talk about, we kind of talk about a little bit about ECG. So I will discuss a little bit about ECG, a little bit more detail. I think at the end of last week, we kind of skipped this over. So what is an ECG? ECG and EKG are identical. The only difference between the C and the K is in German, they use the K for cardiogram. In America, in England, we use the C for cardiogram. So we use ECG, but the actual wave patterns are identical. The words are just kind of different. So in an EKG, we should see electrical discharge. So when we see an electrical discharge, the first discharge is when the atria depolarizes. Keep in mind, like skeletal muscles, cardiac muscles need to depolarize before they contract. So when you depolarize, it's like you're turning that muscle on. As you're turning the muscle on, you release calcium. The calcium has to take time to bind to troponin. Troponin needs to move tropomyosin out of the way. And then you need to have actin and myosin interact. That takes a little bit of time. So the actual contraction of the atria usually doesn't happen until halfway through the P wave. The P wave right here is just the depolarization of the atria. Halfway through the P wave is when the actual muscles of the atria start to contract and create pressure. So what else does a P wave then, what does it measure? It measures atrial depolarization. But why does the atria depolarize? The atria depolarize because it receives the message to depolarize from our pacemaker, our SA node. The presence of the P wave is a sign that the SA node is functional. If the SA node is not working, you will have a very, very spread out P wave or even an absent P wave. Now, that's just for atrial depolarization. The big one is this QRS complex. QRS complex is ventricular depolarization. And halfway between the R and the S, that's when the actual ventricular contraction occurs. So again, discharge is this big old waveform Q to R, and then halfway through the R is when the myocardial muscles of the ventricles start to contract. Now, what else does this big old QRS complex show? It shows that the AV node is functional. What we want to see is a very, very sharp QRS complex that is not spread out. If it's spread out, it means that you are no longer synchronously contracting the ventricular muscle. When the SA node fires, it sends a signal down to the right and the left bundle branches. At about the same time, all of those muscles will receive the signal to contract. If your muscles are healthy, as soon as they signal the muscles to contract, the bundle branches discharge, and then you'll depolarize the myocardial muscles of the ventricles almost all at once. A healthy heart, you should see that, where you might see a very large QRS, but it's very, very thin. We want a very thin, pretty enlarged QRS, and it's a sign that your ventricular muscles are able to discharge as soon as they get the signal from the depolarization of the AV node. The next waveform is a T wave. The T wave is going to be ventricular repolarization. And the T wave is going to signal the end of our contraction cycle of the ventricle. Just like what we saw before, no real changes in the pressure until halfway through the T wave. Then we start seeing some of the muscles fully relax. So then as they fully relax, you can't maintain pressure at that point. And then we should start seeing a drop in pressure afterwards. Notice that you see a ventricular repolarization, but not an atrial repolarization. Why? Because atrial repolarization occurs during the QRS. The QRS is so large, it ablates us ever finding that atrial repolarization waveform. Now, these are just examples. I'm not going to have questions regarding, specific diseases that you have to diagnose, but keep in mind, when we do have arrhythmias, MIs, we can use an ECG. What ECGs are not good for is when you have a murmur. When you have a cardiac murmur, you will have to do some kind of ultrasound, right? So then you can figure out which of the heart valves are actually affected. But when you have an arrhythmia, when you have an MI, this is the gold standard for diagnosis. This is a prolonged QRS complex that I was just mentioning that's indicative of a bundle branch block, right? So what happens is normally the AV node fires. As it fires, think of the AV node is connected to wires. The wires are the left and the right bundle branches. As soon as the AV node fire, then the left and the right bundle branches receives a signal and then sends it to the ventricular cardiac muscles. Now, if your ventricular muscles sometimes are not functional or there's a blockage in one of the wires, well, if you get a blockage in one of the wires, some of the signals might be delayed getting into part of the myocardium. And you'll have some signals that gets received. And then the myocardial muscles that receives it fires right away. But because you have a bundle branch block, other signals that should go immediately to the ventricular muscle instead gets delayed. As it gets delayed, then you have this prolonged QRS, signaling that some muscles receive the signal and they're able to depolarize immediately. Other muscles had to wait because of that blockage. They receive the signal a little bit later and then they depolarize immediately. Because they have to wait, instead of a nice sharp QRS, you have a nice prolonged QRS right here. This is the worst type, right? In AFib, notice you don't see any P waves before QRS. You don't even see any T waves. Now, the good news about AFib is that you can survive on AFib, right? Usually people on AFib, we're worried about throwing clots, having pulmonary emboli, throwing clots into the brain. So we don't immediately shock them back to normal cardiac rhythm. Instead, we give them warfarin, all right? So then, or if they're gonna be in the hospital, we can give them warfarin via IV or Coumadin. So then they can thin the blood a little bit. So then there's a lesser risk of throwing out clots. And then we shock them back to normal sinus rhythm. So we can even have time to wait a week, 2 weeks, when people are in AFib before we shock them back to normal cardiac rhythm. This is a dangerous one, VFib. VFib have what we call a sawtooth appearance on an ECG. And that's a sign that if you see this, the ventricular muscles are shaking instead of contracting. Because it's shaking, it's no longer ejecting blood out. This is an immediately life-threatening condition, and they need to be shocked back to normal cardiac rhythm. This, if you've ever seen like the AEDs that are in buildings at MATC, we have a couple of those. We have one of those in every floor. At every school, they should have one of those. The AEDs, the automatic defibrillator, automatic electrical defibrillator, right? Well, those AEDs are to shock people back to normal sinus rhythm when they're in VFib right here. You can't live with VFib, right? I think we ended talking about this cardiac cycle. I want you to review this again, right? I do have a video just on it that I just posted last week where we talk about the P wave right here. The P wave then causes this, right? It causes a slight increase in the atrial and ventricular pressure. Why both? Because you're ejecting blood from the atrias with the same pressure. And then the left ventricle receives the blood and receives it under the same pressure. So you have a mirroring of pressure changes here. Since we're ejecting blood, we also have increased blood volume right here. So at rest, this active ventricular filling time just kind of polishes off, tops off the remaining amount of blood. So then we go from 100 milliliters to 120. It becomes very important when our heart rate increases though, this active ventricular filling area, right? This phase is very important when your heart rate increases. Then you have the QRS. With the QRS, it stimulates a little bit after halfway through the R complex. Then the left ventricle right here starts to contract. As you contract to prevent backflow, one of the first things that happens is left ventricular contraction exceeds left atrial contraction. When that happens, the pressure change, the left ventricular contraction pressure is greater than the atrial pressure. That left ventricular pressure causes closure of that mitral valve to prevent backflow. So when we see the word isovolumetric, whether it's contraction or relaxation, whenever you see that word, all four valves are closed. As all four valves are closed, the aortic valve was closed from the previous relaxation phase. We just closed the mitral valve, and the same thing is happening on the right side. So all four valves are closed. All we're doing here is creating a pressure difference right now, right? We're maintaining, right? We have to get to 80 millimeters of mercury right here of pressure to open the aortic valve. We started at 10. So we can't go from 10 to 80 immediately, right? So we have to build up that pressure. As we build up the pressure, since all four valves are closed, there's no volume change, right? Eventually the pressure in the left ventricle exceeds the pressure in the aorta. You pop open the aortic valve and you keep ejecting blood out. As you keep ejecting blood out at this point, the aortic and the pulmonic valves are open right here. The mitral and the tricuspid valves are still closed to prevent backflow. As we eject that blood out, that blood we ejected out then is about 70 mLs, right, is our ejection. Our stroke volume is 70 mLs. And then eventually as I eject that blood out, there's only so long I can maintain ventricular contraction. So the T wave right here, well, what do we see with the T wave? About halfway through the T wave right here, the pressure starts to drop as more and more ventricles repolarize and relax. Eventually the pressure in the ventricles is lower than the resistance pressure in the aorta. Then blood moves backwards because of resistance in the aorta, causing closure of that aortic valve. As the aortic valve closes, you see this slight increase in pressure in the aorta. We call that slight increase the dicrotic notch. What else do we see here, right? The left ventricular pressure is gonna, at this point, the aortic valve closed. At this point, on the right side, the pulmonic valve will close. The mitral and the tricuspid valve close way over here. It hasn't reopened yet. So all four valves are closed again, starting in the isovolumetric phase of relaxation. All we're doing here is just decreasing pressure now from 100 all the way down to 0. Now, I always like to ask a question. Can you describe the difference between systolic blood pressure and diastolic blood pressure? Can you tell me? Don't tell me the numbers. Don't tell me what one is worse than the other, right? What do we mean when we're measuring systolic blood pressure? Since you're here, I'll tell you. For everybody else, they might need to know it for the test, right? Systolic blood pressure is indicative of our left ventricular pressure at full contraction. Sometimes it's also known as an aortic pressure at full contraction. Now, how come those two can be interchangeable? Well, take a look. Your aortic pressure, your left ventricular pressure are identical. Why? Because as blood is being ejected, it's ejected under the same pressure as the blood that's being received in the aorta. Since the blood's going to aorta next, it's going to receive the same pressure, right? That's why you see these pressures mirroring each other. So systolic blood pressure is the maximal pressure that is measured during left ventricular systole, which also correlates with the maximal pressure when we measure the aorta. That's systolic. Diastolic is something different, and we'll talk about it in chapter 20. So this is just a kind of review of this. I do have a video just on this, and it kind of describes what happens with the heart sounds as well. All right, now there is a video where I talked about this part, but it did not work well. I think it did not tape because the sharing didn't work.